Hello everyone, this is TBL Group 17. Today we are going to present the clinical case 1. So let's begin. This is the description for case 1. We will have a summarized description in a few slides later. Then we proceed to the 3 questions of the case. First, the choice of anti-diabetic agent for her after discharge from hospital. Second, the justifications. Third, what are the important issues that needed to be addressed with Miss A? The important medical history for Miss A is she doesn't have any family history of diabetes mellitus. She has 1-day history of difficulty breathing, abdominal pain, and vomiting. She also has polyuria, polydipsia, and weight loss for 1 month duration. Her plasma glucose level is elevated. Her HbA1c is high, her BMI is low, and also her serum bicarbonate level is low, based on the investigation. To answer question 1, the most suitable anti-diabetic agent as treatment for Miss A would be insulin. The type of insulin prescribed will vary depends on the patient's age and activity level. Also, how long does the patient's body take to absorb the insulin, while also how long does the insulin stay active inside the body. So, to choose the correct insulin, we can refer to the table on the right.
So, for the justification of the treatment, which is question number 2, we chose insulin because she most likely has type 1 diabetes mellitus, a condition in which the body does not make enough insulin due to autoimmunity against beta cells of the islet of Langerhans, and therefore cannot control the amount of sugar in the blood. The lack of insulin, which means lack of glucose metabolism, together with the increased glucose demand, especially with stressors, causes the body to compensate by gluconeogenesis, glycogenolysis, and lipolysis, which eventually leads to diabetic ketoacidosis, DKA, due to the excessive fatty acids and accumulation of ketone. Therefore, insulin needs to be constantly introduced into the patient so that the patient can have normal glucose metabolism and inhibit lipolysis and ultimately prevent acidosis from occurring. The following are the indications for type 1 diabetes mellitus. The patient is young and thin, no family history of diabetes mellitus, high HbA1c level in which she had 12%, presence of anti-GAD antibody, and DKA, which occurs frequently in type 1 diabetes mellitus. Important issues that need to be addressed. Blood glucose monitoring. Self-monitoring of blood glucose should be performed 4 to 6 times a day, more frequent in certain conditions such as sick day or exercise. Follow up with doctors to check whether the condition is well controlled or if they need any changes in the insulin dosage, or to rule out any diabetic complications like retinopathy, nephropathy, neuropathy, and macrovascular complications. Next would be injecting insulin. The use of stimulation tools combined with operating videos and manuals as a standard process for guiding patients in insulin injection training can ease the patient's fear of injection, provides more practice, and improve the insulin injection skills of the patients. Next would be counting carbohydrates. It is a meal plan approach for type 1 diabetes mellitus patients, focusing on carbohydrates, which is the primary nutrient affecting postprandial glycemic response. Dehydration. Fluid replacement should begin before starting insulin therapy. Initial fluid therapy will depend on whether the patient is in shock, 7 to 10% dehydration, or 5 to 7% dehydration. Moving on to IV potassium replacement. Major loss of potassium is from the intracellular compartment, and this is further aggravated by vomiting and osmotic diuresis. Weight management. Meal replacements, healthy but higher calorie foods, smaller portions but more frequent, exercise to build muscle, and as well as hydration is very important. Lastly, follow up with doctors to check if the condition is well controlled and if there is a need for any changes in the insulin dosage. And that is all from us. Thank you very much.